pertanyaan, peserta dapat menuliskannya di chat atau nanti saat sesi diskusi dapat dipandu oleh moderator untuk langsung bertanya saat sesi setelah pemaparan. Nah, sebelum itu, di sini ada pemberitahuan terlebih dahulu bahwa keseluruhan acara ini akan direkam dan disiarkan live di YouTube oleh panitia penyelenggara untuk kebutuhan dokumentasi. Nah, untuk Bapak Ibu, apakah ada yang keberatan jika kegiatan ini direkam? Bila ada Bapak Ibu yang keberatan untuk saat ini direkam kegiatannya, Bapak Ibu boleh saja mengganti nama Zoom ini untuk menjadi anonim agar nanti saat direkam bisa tidak tercatat namanya. Seperti itu. Baik, untuk melanjutkan, ini adalah sedikit ketentuan sesi diskusinya. Sedikit ketentuan sesi diskusinya, nanti akan ada rekan saya yang akan membantu memfasilitasi sesi diskusi, dan nanti peserta yang ingin bertanya atau memberikan komentar terkait pemaparannya bisa melalui kolom chat ataupun langsung bertanya kepada para pembicara nanti dengan mengaktifkan fitur raise hand atau nanti bisa langsung membuka mikrofon atau video untuk mengajukan pertanyaan secara langsung kepada para pembicara. Nah, di sini kita memberikan sedikit fasilitas interpreter. Di sini ada Mas Yuri Satya yang nanti akan membantu rekan-rekan sekalian dalam memberikan fasilitas interpreter ini. Jadi untuk sedikit panduannya, pada kolom di bawah Zoom, pada kolom Zoom bawah Bapak Ibu, bar di bawah, di situ akan ada fasilitas simultaneous interpretation. Dan di sini untuk mengakses fitur ini, Bapak Ibu bisa menekan tombol di bawah tersebut yang berbentuk seperti bola dunia atau globe, dan nanti pada tombol tersebut akan ada tulisan English atau Japanese atau bahasa Indonesia. Biasanya kalau Zoom yang versi lama itu tulisannya English dan Japanese, tapi kalau yang sudah versi baru bisa langsung English dan bahasa Indonesia. Nah, untuk Bapak Ibu jika Bapak Ibu ingin mendengarkan dalam bahasa Inggris, Bapak Ibu dapat memilih English, dan jika ingin mendengarkan dalam bahasa Indonesia, Bapak Ibu dapat menekan tombol bahasa Indonesia atau Japanese pada fitur tersebut. Dan untuk menggunakan fitur ini secara maksimal, Bapak Ibu dapat menekan tombol mute original audio agar audio yang terdengar oleh Bapak Ibu bisa terdengar lebih jernih untuk salah satu interpretasinya. Oke, ini adalah sedikit outline kegiatan untuk hari ini. Sebentar lagi kita akan melakukan pembukaan dan kata sambutan, dan akan dilanjutkan oleh pemaparan oleh narasumber. Kita sudah kedatangan 3 narasumber hari ini, dan nanti juga akan dipandu oleh seorang moderator pada sesi diskusi dan tanya jawab setelah itu, dan terakhir nanti akan ada sesi penutup dan foto bersama. Oke, kita masuk ke sesi kata sambutan. Berikut adalah kata sambutan dari Ibu Evi Sukmaningrum selaku Kepala PUPT PPH Pusat Unggulan Kebijakan Kesehatan dan Inovasi Sosial Unika Atmajaya. Untuk Bu Evi, waktu dan tempat saya persilahkan.
Baik, saya tidak akan lama-lama mengambil jatah dari waktu ini karena sepertinya seminarnya akan jauh lebih menarik dan penting, tapi saya akan membukanya. Assalamualaikum warahmatullahi wabarakatuh, salam sejahtera bagi kita semua, semoga Bapak Ibu dalam keadaan sehat senantiasa. Ya, sebelumnya saya terima kasih juga untuk 3 pembicara utama. Saya mau menyapa dulu, Hai Ben, Kristal, Priyanka, terima kasih sudah hadir untuk memberikan seminar di sini. Dan terima kasih juga untuk moderator yang akan mandu seminar hari ini dari PPH Unika Atmajaya, Amalia Purihandayani. Jadi acara ini kami selenggarakan sebagai bentuk kolaborasi dari University of Melbourne, Australia, dan PUPT PPH Pusat Unggulan Kebijakan Kesehatan dan Inovasi Sosial. Ya, sepertinya ini jadi momen penting ya, karena sebenarnya kalau saya lihat di list partisipan sepertinya semua ini sudah pasti ada di field HIV, jadi pasti sudah mengetahui tentang Kaskade Perawatan ini, dan kita semua mungkin mewakili, kita mewakili semua gitu ya, yang ada di dunia dan isu HIV ini sudah mengenal istilah ini ketika, mohon dikoreksi bila saya salah, sepertinya kurang lebih tahun 2016 ya, ketika diresmikannya deklarasi politik PBB pada seluruh negara untuk berkomitmen mengakhiri AIDS melalui pencanangan target 90-90-90 ini. Nah, kemudian pada tahun 2021 ini ya, dalam sidang umum PBB melalui pertemuan tingkat tinggi terkait AIDS yang baru saja berlangsung di New York, Amerika Serikat, tanggal 8 sampai 10 Juni 2021 kemarin, seluruh negara anggota PBB termasuk juga tentu saja negara kita, Indonesia, juga mengadopsi deklarasi politik tentang HIV dan AIDS untuk menghentikan ketidaksetaraan untuk kembali dalam jalur untuk menghentikan AIDS pada tahun 2030. Dan disepakati pula bahwa target yang perlu dicapai dalam 5 tahun mendatang dalam deklarasi tersebut. Dan jika kita semua bisa mencapai target tersebut, maka seluruh dunia ini juga bisa mencegah 3,6 juta infeksi baru HIV dan mencegah 1,7 juta kematian karena AIDS di tahun 2030. Dan sekarang ini di 2021 mungkin dari 90-90 menjadi 95-95-95-95. Jadi saya pikir seminar hari ini juga akan suatu hal yang penting untuk membantu kita bersama-sama melihat dan mengevaluasi bagaimana model data Kaskade Perawatan HIV dalam konteks Indonesia ini, ya sejauh mana itu memang fit, sehingga apa saja kritik dan implikasi dari model data Kaskade tersebut sebagai standar perawatan HIV, dan juga bagaimana penggunaan model data Kaskade dalam program HIV. Yang saya sudah nggak sabar juga untuk mendengarkan ya dan untuk mempelajari bersama. Jadi sekian pengantar dari saya, mari kita sama-sama menikmati seminar hari ini dari pembicara handal kita. Terima kasih.
Baik, terima kasih banyak Bu Evi atas kata sambutannya. Selanjutnya, tanpa berlama-lama lagi, kita akan memasuki sesi pemaparan materi oleh para narasumber, dan nanti akan dipandu oleh rekan saya, seorang moderator, bernama Amalia Purihandayani. Beliau merupakan seorang peneliti di Pusat Penelitian HIV/AIDS Atmajaya sejak tahun 2019, dan beliau memang sangat aktif mengikuti berbagai macam lokakarya, seminar, dan pelatihan di bidang kesehatan, pemberdayaan perempuan, dan masih banyak lagi. Baik, tanpa berlama-lama, Mbak Amal, waktu dan tempat saya persilahkan.
Terima kasih banyak Mervin dan Mbak Evi yang udah membuka acara ini. Selamat datang teman-teman di Seminar Internasional The Kaskade of Care. Sebelum kita mulai, saya mau memperkenalkan para narasumber hari ini. Yang pertama adalah Benjamin Hegarty. Kami biasa memanggilnya dengan Ben. Beliau adalah akademisi interdisipliner di bidang seksualitas dan gender di University of Melbourne. Dia bergerak di area penelitian sejarah transgender, globalisasi, pengetahuan keberagaman gender, dan ekonomi politik dari Layanan HIV di Indonesia. Ben juga menulis buku The Made Up State, Cornell University Press. Ben juga salah satu research fellow di PPH Atmajaya, dan penelitian terakhir yang dilakukan bersama dengan PPH Atmajaya adalah dampak COVID-19 terhadap penjangkauan dari laki-laki yang melakukan hubungan seks dengan laki-laki di Indonesia selama COVID-19. Pembicara yang kedua adalah Crystal. Crystal merupakan spesialis di bidang data penelitian di Melbourne Data Analytics Platform. Dia memiliki ketertarikan di bidang penelitian seputar data, etika digital dan data, musik, dan psikologi, serta semiotik. Selamat datang, Crystal. Pembicara yang ketiga adalah Priyanka Pillai, akademik spesialis di University of Melbourne dengan latar belakang bioinformatika dan ilmu komputer, termasuk di research data spesialis di Melbourne Data Analytics Platform juga bersama dengan Crystal. Health Informatics Specialist di Australian Partnership for Preparedness Research and Infectious Disease Emergency Center of Excellence. Selamat datang, Priyanka. Teman-teman, hari ini kita akan mendiskusikan implikasi pendekatan 1990 atau 90-90-90 terhadap pencegahan HIV atau yang biasa disebut dengan Kaskade. Ada dua komponen utama dalam pengumpulan data Kaskade, monitoring dan evaluasi, yang kedua surveillance dan survei. Ketiga narasumber akan menjelaskan lebih lanjut tentang maknanya di antara monitoring dan evaluasi dan surveillance and survey, karena maknanya bisa bergeser sesuai dengan konteksnya. Untuk waktu dan tempat, saya persilahkan buat Crystal. Over to you, Crystal.
Thank you very much, Amalia. Priyanka, are you able to share your screen? Excellent. And you're not yet in presenter mode, Priyanka. Some issues with your audio.
Still, I'll be able to hear you now when you say next slide. Sorry, I couldn't hear you before.
Yeah, no trouble. Thank you. And you're not yet in. Yeah, perfect. Fantastic. Thank you, Priyanka. Thank you so much. Thank you to everybody for having us along today. Before we start, I'd like to thank the organisers of this seminar. Thank you so much, Amalia, and your colleagues for hosting this seminar and for organising it. It's so wonderful. Thank you also to the interpreters. Thank you to Yuri. It's so wonderful to be able to speak to you today. In Australia, before a gathering, it's common practice to acknowledge the traditional custodians, the First Nations people of Australia, on whose land we live and work. So before I begin, I'd like to acknowledge that we in Australia are gathered both physically and virtually on the lands of the Wurundjeri people of the Kulin Nation, who have been custodians of these unceded lands for many thousands of years. The University of Melbourne is situated on the lands of the Wurundjeri and the Boonwurrung, the Dhardarung people, the Yorta Yorta Nation, and the Wadawurrung people. We acknowledge and pay our respects to their elders past, present, and emerging. Okay, could you go to the next slide, please, Priyanka? Thank you. So the content that we are speaking about today is based on and is an extension of a preprint article that we have recently produced. And the citation for that article is on your screens right now. This article examines how the cascade of care shapes processes of data collection and data flow. The impetus for this work was born out of the observation that data about the HIV epidemic is rapidly expanding. This includes both data about modelling as well as the collection of epidemiological information about people living with HIV. One of the main drivers behind this rapid expansion is the political momentum to end AIDS through data-led initiatives to testing, treating, and tracking the epidemic. Next slide, please, Priyanka. Thank you. In 2016, the World Health Organization emphasized the collection and use of data as a key strategy for implementing tailored responses to the HIV epidemic. As the report outlines, quality data are required to measure service access, service uptake, populations covered, quality, and acceptability along the entire continuum of HIV services. The continuum of HIV services frames much of the HIV data collection process. Related to the continuum is the HIV cascade of care, and it is this that our paper today will focus on. The HIV care cascade has many different names, including, for example, the Cascade of Care. And for simplicity, in this paper today, we will refer to it simply as the cascade. The cascade is used as a standard across international development funds, especially for international mechanisms like Global Fund. In these contexts, the cascade may take on different definitions and different meanings. Next slide, please, Priyanka. Thank you. So for this reason, we'll begin the paper today with a discussion of the different models of the cascade, and this discussion will be led by Ben. While the cascade may be defined differently in each context, it is always underpinned by principles of monitoring and evaluation and surveillance and survey. At the same time, the idea of the cascade influences how these principles are defined. So following the discussion of the different cascade models, Priyanka and I will then discuss the terms monitoring and evaluation and surveillance and survey in the context of the cascade. So our paper will then conclude with a discussion of the working definitions of these terms and their implications for data-led approaches to ending AIDS. And after this, we'll open the floor for discussion led by Amalia. So with that, I'm going to hand over to Ben. Thank you very much.
Thank you so much, Crystal. Can you hear me okay? Great. So yeah, like Crystal, I'd just like to echo that gratitude to PPH Atmajaya and also to the audience for tuning in to listen to our really what is a kind of a new research focus for many of us. And we really invite your interest and expertise in this area to kind of contribute to the picture that we're trying to paint of the cascade of care and its usefulness and also perhaps its shortcomings in the Indonesian context. So I guess the first thing that, sorry, we'll just go to the next slide if that's okay. So the first thing to say, of course, about the cascade that might seem not immediately obvious is that it's not only about care. The cascade of care is, of course, underpinned by and represents a data system, which is complex. However, of course, the idea behind the cascade of care is that it manages to kind of simply, in a world of kind of vast complexity, really simplify the presentation of the current state of the HIV epidemic and efforts to address it. The ways that it does that is, of course, to break down the steps, drawing on really what would be a narrative pathway through a clinical experience, although you can see here sometimes the cascade is actually extended beyond diagnosis with HIV to estimates of people living with HIV, which is another kind of question, I guess, that we have about the data that's collected. But that nevertheless, that it kind of draws on that narrative experience and kind of attempts to scale it up, right, through the collection of vast amounts of data from around Indonesia and indeed around the world. So the slide here, you can see, gives a nice kind of illustration of the various ways in which, even in one report from the WHO, I think this report is, which kind of shows the different kinds of data that is drawn upon to represent the HIV epidemic as a cascade, but also kind of which takes on kind of different kinds of data to do so. Crystal has nicely kind of broken it down into the 3 steps, which you'll be perhaps more familiar with: diagnosis, treatment, and suppression. But you can see, for instance, in image A or figure A, that you've got other steps along the way, right, both before diagnosis and after it. So you've got the estimate of people living with HIV and those in HIV care. And then in between treatment and suppression, you've got an additional step, which is retained in care or retained on antiretroviral therapy. So you can see here that even though a kind of the cascade is imagined as having these 3, universal replicable steps that can be, by which countries can be compared with one another side by side as they kind of track towards, I guess, ending the HIV epidemic. in fact, what's being measured could be rather different. And there are some questions that I guess we have as well about, for example, viral load suppression as an identifiable end goal. To what extent is that, I guess, a feasible feasible form of data to be collected and then stored, say, in the Indonesian context and more broadly. So I'll just go to the next slide if that's okay. Thank you. So the second aspect that I wanted to introduce is the kind of link between the Kaskade of Care as a data model and the emergence of, I guess, treatment as what's sometimes called treatment as prevention, which you can see kind of illustrated in this slide in the linkages Kaskade framework in a publication from 2016. I think it is a guide. Or what's alternatively and a slightly different strategy of test and treat, which many of you will be aware of in the Indonesian context. So what the Kaskade relies on, I guess, is a model of HIV care that is closely tied to the widespread provision of antiretroviral, or both testing on the one hand and antiretroviral treatment on the other, in addition to, of course, the capacity to measure viral load and the laboratory services in order to do that. So, of course, in Indonesia, since the introduction of the Kaskade in HIV policy in some format in 2012, in 2018, the Ministry of Health has rolled out a test and treat program on the national level, and this is fast changing, so we invite people to kind of update me on this. And as Elan Laswadi, an anthropologist at UGM, points out, the Kaskade has radically reshaped the meanings associated with HIV care in Indonesia. Yet, despite the kind of proliferation or the kind of widespread use of these kinds of models, right, in both, say, for example, in the linkages framework of internationally funded HIV prevention programs, or indeed, in the Ministry of, say, the Ministry of Health's quarterly reports on progress towards, I guess, quarterly reports on the Kaskade, which are demonstrated in the form of a Kaskade. What we don't really see, I guess, is the kinds of ways in which data is collected and how it's collected, as well as the kind of sensitive or ethical issues surrounding data collection along the way, right, as these steps are taken by lots of different actors throughout Indonesia. So, an assessment undertaken by the World Health Organization in 2018 found, for example, certain issues, I guess, with surrounding data collection or problems surrounding data collection, including the inconsistent use of unique identifier codes, which can facilitate anonymity, and also kind of offer the possibility that you've got the duplication, right, of particular kinds of data or records. The collection of extraneous data or data that you don't really need, for example, that never finds its way into reports. The duplication of clinical data, right, and its reporting through, for example, systems like SIHA, the HIV/AIDS information system, managed by the Ministry of Health, I think, and basically uneven technical laboratory capacity for testing viral load, right, or indeed many other services as well. So you can see that there are lots of kind of ways in which the data that feeds into this model might be interrupted at different points. And so you begin to ask, how effective, I guess, these kinds of ways of visualizing the HIV epidemic are. So I'll just go to the last one, sorry, which I think is, yeah. So you can see, as a model that and this is also from the linkages program, as a model, I guess the advantage of the Kaskade of Care is that it encourages policymakers and others working in the field of HIV that there are many steps along the way for individuals and populations to be able to access both get tested, then to be enrolled in treatment, and then in order to have a suppressed viral load, right, or be retained in care. This is especially acutely felt by key populations. So you can see here that in the linkages program, of course, the focus is on key populations. So the very first step in the cascade is the identification of key populations. So I guess before I invite Crystal to kind of give some more in-depth information about the kinds of data that go into the cascade, I guess I'm interested in how these processes take place. So, how it is that data is collected in order to identify key populations, to what extent that data is able to be shared and visualized adequately, and then what might its uses be, right? What might some of the uses of this vast amounts of data be, so that it really can be deployed in an effective and a timely manner. So over to you, Crystal.
Thank you so much, Ben. Brilliant. Thanks, Priyanka. Okay, so monitoring and evaluation. Let's begin with some definitions. And sometimes I may call monitoring and evaluation MNE for ease of reference, just foreshadowing that. So evaluation is defined by UNAIDS as the systematic collection of information about the activities, characteristics, and outcomes of a specific program to determine its merit or worth. Now, monitoring is less explicitly defined, but it generally appears to refer to the collection of data for evaluating program performance. For example, serosurveillance, behavioural surveys, and routine program monitoring might be considered forms of monitoring. Next slide, please, Priyanka. Thank you. So this figure is an example of a visualization of monitoring and evaluation. It's broadly framed within the cascade logic. There are 8 public health questions, which are organised visually into the 3 cascade steps of diagnosis, know your status, treatment, retained in care, and suppression. Monitoring and evaluation applied to the cascade context thus scaffolds the datification of HIV care. It can be used to set parameters around the steps towards care, which are then quantified in data. MNE does not have to be focused on the cascade, and there are a number of examples of MNE outside of the cascade model. But monitoring and evaluation is always premised on the collection of data. And because of this, the monitoring and evaluation framework is easily applied to the cascade data model. As an example, in answer to the question, what is the problem? The response from policymakers thinking through the cascade is likely to be not enough people on ARP. This might prompt follow-up questions in response to this, such as not enough HIV positive people are virally suppressed, or we don't know how many people on ARPs are virally suppressed. This response to the most fundamental question of monitoring and evaluation then shapes all the subsequent measures. In this way, monitoring and evaluation activities can be easily recast to fit the indicators of the cascade data model. To put it another way, the monitoring and evaluation viewed through the cascade can encourage policymakers to adopt treatment as prevention, thus prioritising biomedical models as core to their efforts in preventing HIV. Next slide, please, Priyanka. Thank you. So the impact of the processes and the purpose of monitoring and evaluation of the HIV epidemic has changed over time. But this change can be characterised broadly as a move towards the cascade model. Measuring progress in terms of the cascade has been the case since the widespread adoption of treatment as prevention. Treatment as prevention, as I'm sure you're aware, is an approach centred on the concept that the widespread rollout of effective treatment could also serve as a form of HIV prevention. But social scientists have critiqued this as heralding an increased biomedicalization of the way that HIV is understood and the way that it is addressed. The consequences of this biomedicalization is that there has been a move away from community-driven and socially complex models. This biomedicalization of monitoring and evaluation in this way further reinforces its use in measuring progress in the cascade. Next slide, please, Priyanka. Thank you. So ultimately, the cascade approach to monitoring and evaluation sees treated HIV as the endpoint of a series of steps through which a patient moves. This endpoint is preceded by testing, diagnosis, linked and accessing treatment, and retention in treatment. Each of these steps is focused on achieving viral suppression so that a person is theoretically unable to infect anyone else. This is driven through a political emphasis on treatment as prevention. So a critique of the cascade and monitoring and evaluation thus defined is that it defines HIV care narrowly in terms of biomedicalization and the goal of viral suppression. Now, this in turn shapes public health surveillance and allocation of resources, particularly towards a focus on those out of care and those not virally suppressed. And to extend on this, in the age of PrEP, this further biomedicalizes the prevention of HIV. It does this through the promotion of targeting of key populations who are currently HIV negative. I'll hand over now to Priyanka, who's going to speak in more detail about how these key populations are defined and also how they're surveilled.
Thanks, Crystal. And as Crystal and Ben said, I would also like to extend my gratitude and express my thanks to all the organizers at Majaya University, Amalia, and the collaborators on this project. I'm very excited to be here and talk to everyone. So, and all the attendees, thank you for attending the talk. So as Crystal started her part of the talk with some definitions, I think it's important for us to focus on the definitions of surveillance, surveying, as those terminologies can be associated with multiple things. In the context of infectious diseases, the United States Centers for Disease Control defines surveillance as the ongoing systematic collection, analysis, interpretation of health-related data essential to planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control. And the UNAIDS WHO working group focusing on the HIV and STI surveillance has added context to this definition by defining surveillance as early warning systems for the detection of changes in diseases or patterns, which allow for the necessary interventions to be put into practice to prevent new infections. So while surveillance is complex, it relies on many different methods of data collection and collecting different kinds of data about the population. So two main types of surveillance are syndromic surveillance, the data that's collected from routine reporting. That includes case reporting, which includes total number of tests undertaken, the number who test positive, number of people who test positive, and the number of people who enroll in care and the activities associated with care, so on and so forth. And sentinel surveillance, which focuses on periodic testing and behavioral surveys among at-risk population. Surveillance for HIV at the broadest level relies on the collection of various kinds of data. And an important feature of not just HIV surveillance, but all sexually transmitted infection surveillance is the focus on key populations. And that's the slide, that's the image that we're looking at now. So components of HIV second generation surveillance that focuses on tracking the epidemic by collecting behavioral and biological data about specific at-risk populations or key populations, as Ben and Crystal spoke to, rather than the entire population as its whole. From the research and all the reading that the collaborators in the group has done, it appears that most of the data collections in Indonesia comprises of second-generation surveillance, the image that we looked at that focuses on very specific at-risk key populations. This information appears to be collected and stored in SIHA, and Ben covered that a bit in his talk, the Indonesian HIV/AIDS online data system, in a systematic manner. Instances of data collection that can be classed as more traditional forms of public health surveillance are also included in SIHA. A method for data collection that informs the MNE used to report the cascade is the periodic biological and behavioral surveys of key populations through the Behavioral and Biological Survey, IBBS in Indonesia, undertaken once every 3 years. And I should mention that this involves a large logistical effort that includes many organizations and field workers which collect various kinds of biological data. And this is where MNE and surveillance and surveying is all tied together. Surveillance is an important part of the data collection mechanisms that makes monitoring and evaluation possible. The slide that Crystal presented that involves multiple steps in the public health process has split those activities across different steps, which also makes us believe that one doesn't go without the other, and they go hand in hand. WHO describes the close relationship between surveillance and monitoring and evaluation in HIV programs with the following key objectives. Surveillance tracks how the epidemic in a region is changing. Monitoring and evaluation activities track how programs are responding to the epidemic. These activities should be designed to be complementary, so the outcomes and outputs correspond to the activities planned. There is limited research about how surveillance is defined relative to the cascade model in Indonesia, and that's the interesting area of work that we want to focus on. We want to look at how the cascade model fits into the entire public health picture and informs monitoring and evaluation and the relation between surveillance and MNE as well. And I'll now hand over to Ben, who will bring all of it together. Thank you.
Hi, thank you so much, Priyanka. I think you've done such a wonderful job. I wonder whether I can bring it all together in any kind of really clearly coherent way, but I'll hopefully just give a brief summary really of what we've discussed and perhaps open up into a discussion. And as I mentioned, we're really keen to kind of invite everybody here to really offer their thoughts both on the presentation, the kind of way that we've described it, as well as the any potential I guess understandings of data that we might have missed, right, or that we might be useful to us. Do you have the slides? Sorry, Priyanka, I think we lost did we lose the slides? Or have I just simply changed?
Oh, sorry, can people see my screen?
Oh yes, we can. I'm
yes.
Sorry, I had the wrong view on my screen. Yeah, great. So basically, oh yeah, if you could go back 2 slides, if that's okay. Thank you. Yeah, so in this presentation, we have, I guess, argued that the cascade of care is a data model as much as it is a health model. That might not seem all that kind of groundbreaking, but I think it's important really to think about the ways in which data is collected and its potential effects, as I mentioned, and its utility, because ultimately what this is doing is making visible the HIV epidemic. It's showing you or directing attention towards particular kinds of problems, but perhaps missing some others. So Crystal and Priyanka helped to kind of illustrate the relationship between treatment as prevention as a kind of, I guess, biomedically focused model, or a model that really relies on the availability of testing and of antiretroviral therapy, and then of the capacity to measure viral load. and its link between that and monitoring and evaluation and surveillance as the kind of frameworks through which data is collected. I've got myself have several questions about the similarities between what what is meant by monitoring and evaluation and what is meant by surveillance. And sometimes they seem rather similar, they overlap, at other times they're kind of separated out. But nevertheless, I think that it's important to bear in mind that the focus appears to almost always be on those 3 90s of testing, enrolling in treatment, and then suppression of viral load, or temukan, obati, pertahankan, right? So I think that's right. So basically, in conclusion, I just wanted to, as I mentioned, this more than a conclusion, an invitation, I guess, for reflections. Oh, sorry, if we could just go back to that slide. Sorry, I'm taking a long time to get to it. So you can see here, as I mentioned, that ultimately what this model does is make visible certain kinds of, it encourages a certain way of knowing the HIV epidemic. So in this case, you've got here, this is the quarterly report from published in 2019 by the Ministry of Health. It's October to December 2019. You can see the monthly report visualized as a cascade with the 3 90s as well, or the 3 goals in the Indonesian context, or targets in the Indonesian context, and the progress towards those targets. Ultimately, what becomes visible in this model here is, to my mind, the very large number of people who are lost to follow-up. So you can see here LFU being the kind of acronym used, or those who, in the end, the very small number of people who are displayed in the cascade as having a suppressed viral load. Again, I think it's hard to know whether the number of people who are shown here, or the relatively small number of people who are shown to have a suppressed viral load, is whether that's because in reality there's a very low number of people who have a suppressed viral load, or perhaps that viral load, the capacity to test for viral load is not widely distributed or not widely available. So seeing the cascade as a data model, I think, helps to kind of ask these questions and then ask what might be done about it, whether that's to kind of adjust the model, right, so that it's more suitable to the kind of, I guess, technological or medical context in Indonesia, or perhaps seek to expand the access to technological medical technologies in Indonesia, and both might be necessary. So I'll just go to the next slide before I wrap up. So these kinds of models, I think, are important to think about and look at when we're considering, again, what is shown in, or at least help us to understand, perhaps, in the dominant processes of collecting data about the HIV epidemic in Indonesia, and that is, it would appear to me, to be largely through the Cascade model, not through some other model. You can see, for instance, the various steps at which data from patients is collected in this 2015 guide for contained in CHUB. On the left, you've got a report for, these are both published by the Ministry of Health. You've got an illustration of monitoring and evaluation and a relationship between different kind of scales of governance in Indonesia. So this kind of suggests to me, in a sense, the importance of understanding, I guess, the political context additionally. So it's not only the kind of, I guess, technical aspects of the capacity to collect data, but also the kind of political scale, right, that make data collection, complicated, or perhaps make it require perhaps different ways of thinking about data collection in different contexts. But I would again, love to hear people's thoughts on this, particularly those who have experiences working with the Kaskade as a data model. Thank you very much.
Terima kasih banyak. Thank you so much, Ben, Crystal, and Priyanka. I'm going to speak in Bahasa Indonesia, so you can go to the interpretation and go to the English version. Terima kasih banyak, Ben, Priyanka, dan Crystal. Saya hanya mau memberikan beberapa poin penting yang sudah dijelaskan sebelumnya. Dalam penjelasan mereka, Kaskade dilihat sebagai modal yang universal, tapi sebenarnya bisa digunakan dengan cara yang berbeda-beda, sangat bergantung dengan konteksnya. Ada beberapa isu juga dalam pengumpulan data, tadi sudah disebutkan, misalnya dari cara metode pengumpulan data yang sudah diambil, tapi kemudian belum digunakan, terus ada juga duplikasi data, jadi kemudian pertanyaan yang muncul adalah seberapa efektif cara seperti ini dalam memvisualisasikan epidemi HIV. Bagaimana proses ini berlangsung untuk mengidentifikasi populasi kunci dan seperti apa kegunaannya. Monef nggak harus difokuskan pada Kaskade, tapi selalu ada kaitannya dengan pengumpulan data. Dan sebenarnya yang lebih mudah digunakan adalah Kaskade. Masalahnya yang tadi dijelaskan oleh Crystal adalah seringkali tidak cukup orang atau sumber dayanya. Dampak dari Monef sudah berubah seiring waktu dan dipusatkan pada konsep pengobatan yang efektif sehingga muncul istilah biomedikalisasi tersebut. Monitoring dan evaluasi dapat jadi pertimbangan pembuat kebijakan dalam mengadopsi perawatan sebagai pencegahan, namun penggunaan model biomedikal ini malah mempersempit tujuannya itu sendiri. Kritiknya ada beberapa karena biomedikalisasi ini meningkat, konsekuensinya ini menjauhi pendekatan sosial yang tadi sudah dijelaskan. Kemudian kritik dari Kaskade itu sendiri, pengobatan HIV dilihat secara sempit dan dengan melihat penekanan viral load-nya ini. Saya melihat ada banyak sekali teman-teman yang sudah hadir pada hari ini. Kami senang sekali kalau teman-teman punya komentar, pertanyaan, atau kalau mau menceritakan pengalamannya tentang pengumpulan data, bagaimana data itu digunakan secara di dalam organisasi teman-teman, misalnya apa tantangan yang teman-teman temui, teman-teman boleh raise hand, atau juga boleh berbagi di kolom chat. Di kolom chat ada beberapa, saya akan, ada satu teman yang raise hand. Silahkan, Verikam.
Ya, oke. Terima kasih. Saya akan bertanya pakai bahasa Indonesia ya. Terima kasih sekali buat Ben yang harum namanya, dan Crystal dan Priyanka. Presentasinya sangat menarik saya kira ya, untuk menjelaskan tentang bagaimana situasi kita dan melihat sedikit di balik itu. Nah, saya punya pertanyaan sedikit itu tentang bagaimana Anda, Ben atau Crystal atau Priyanka melihat sebenarnya data selain dari Kaskade itu kan sebenarnya kita punya banyak ya. Ada data tadi surveillance, ada data IBBS, ada data intervensi sendiri dari tahun ke tahun kita punya banyak gitu. Linkages datanya sangat bagus gitu. Kemudian termasuk di Global Fund sendiri yang disupport pendanaan Global Fund. Nah, bagaimana Anda melihat apakah data-data yang terkumpul dari CSO ini kebanyakan itu berarti dalam gambar Kaskade ini, atau letaknya di mana? Atau memang tidak perlu diperhitungkan sama sekali gitu ya. Jadi terima kasih. Itu yang pertama. Dan yang kedua tentang kalau boleh, kalau yang kedua itu kalau misalnya itu belum bisa ditaruh di sana, apakah ada sesuatu yang dihasilkan dari intervensi itu harusnya ditaruh di dalam data gambar itu. Jadi representing Indonesia itu bukan hanya dengan Kaskade saja gitu ya, tapi harus ada gambar yang lain yang membuat oh ya ini maknanya program AIDS di Indonesia itu. Jadi nggak jelek-jelek banget gitu ya apa. Karena kalau pakai itu saja ya sudah 20-30 saya kira juga omong kosong gitu ya. Sorry bukan omong kosong tapi itu mimpi saja gitu. Jadi tapi taruhlah misalnya saja tadi data tentang viral load gitu ya. Berapa data klinik atau tempat yang bisa menyediakan viral load di Indonesia? Kita bermimpi seperti ini harapannya. Tapi kalau jumlah layanan sendiri sangat terbatas kan ya harus kita taruh itu. Terima kasih.
Terima kasih, Mas Ferry. Teman-teman dari University of Melbourne, ada yang mau menjawab?
Oh, sorry, would you like us to, shall we respond?
Yeah, please.
Yeah, great. Crystal, did you, or Priyanka, did you have any?
Yeah, I have some thoughts, but I'm happy for you to open if you like, Ben.
No, go ahead, Crystal, and I can
okay.
follow up. Yeah.
Thanks, Ben. And thank you so much for the question. I'm thinking as I'm speaking, so I'll do my best to make it coherent. And as Ben said, we're really grateful for this opportunity to discuss these ideas that we're still working through. So we're very grateful for these very thought-provoking questions. To your first point about what is the place of other data in the Kaskade data model, so my experience is not in the HIV context specifically. I have experience in digital and data ethics, in data management, in data stewardship. And from my experience with the Kaskade through this work with Ben, it seems to me that the data model, although it is often articulated as being about, testing, treatment, suppression, actually a lot of the data that is often described as underpinning the Kaskade is substituted for other data. And Ben and I and Priyanka and Amalia, we've discussed this before as well. So I'm sharing sort of the group's discussion here, not just my own thoughts. And so in this, I think this is a double-edged sword in some ways, in that, yes, this is great that there is a place for many different kinds of data within a singular data model. On the other hand, this is sometimes confusing, and the data models in general can sometimes paint different pictures by the use of different data when it's theoretically articulated as being based on one data source, and then another data source is substituted for various reasons. So I think there is a place for other kinds of data in the model, and I think the context is really important there. Ben, did you?
Yeah, it's such a wonderful question. Thank you so much. Sorry, what is it? Ferry? Is that
Ferry Kamil? Yeah.
Yeah. Thank you so much, Ferry. Yeah, I think this is such a great question. I mean, what you see often too, if you do some work on the ground with CSOs, is that there's a huge amount of time spent collecting and storing data, right? And so the question becomes like, what's all this data for if it's never kind of visualized? Apart from anything but a cascade, which has these kind of narrow checkpoints, right? Or these simplistic checkpoints in a way. As if all people living with HIV are able or capable, or the structural conditions exist, I guess, for them to be able to move to the point of viral suppression. So that's the kind of first point that I would have, would be to say that a problem arises, I think, when the model is when you have data collection simply for the sake of data collection, right, or simply for the sake of targets. That, I think, kind of in a sense narrows the scope through which you can kind of nimbly and innovatively kind of shift focus one way or another. So I think it would be really worthwhile to kind of look in some depth at the kinds of data that CSOs are collecting, and think about the kind of utility of that. Like, what is it doing? How might it be used? Or if it's not being used, then perhaps it needn't be collected to begin with. Because ultimately, what that model shows, in a sense, as well, is huge amounts of work. At each point along the line, you've got somebody who's filling out a form, who's kind of submitting some data into a system, who's doing data entry. So it's a vast amount of resources that are required to sustain this system. And I think that those are the kinds of questions that are really important. The other space that I was thinking is sometimes you see, and this was the point that Crystal raised about the use of the exchangeability, right, or the flexibility of the cascade, because it's not as though the cascade is completely, rigid, because otherwise it wouldn't, in some instances, it wouldn't be very useful. So I saw a recent article that was by, is it Tarigan? Let me just quickly, sorry, I should have everything ready.
Yes, Tarigan.
Tarigan, that found, through studies done in several of the pilot sites for test and treat, that test and treat is an effective effective model. But if you look closely at the kind of way in which they use the cascade, right, to measure whether or not it was can be found to have been effective in those contexts. But if you look at the last step in the cascade, they exchange suppression of viral load for retention in care or loss to follow-up, right, as the proxy data, I guess, for suppression of viral load. So there is a degree of flexibility there, so obviously data tells a story, but people and I guess policymakers use that data to tell the story. So I guess a little bit more attention maybe to, the different ways in which data is used and how it's kind of can be fleshed out by epidemiologists and medical researchers, researchers more generally. You see the cascade of care and data about data that is informed by it, collected in all kinds of ways. So another instance, it might be the Hutty study, that show looking at their great article, which is about the cascade of HIV care among key populations, the prospective cohort study that they did, for instance. And I think that study combines an in-depth attention, data, ultimately, which is data. It doesn't just look at the kind of biomedical, the cascade, I guess, is a biomedical model that has these various, checkpoints that can be measured only in this very rigid way, but rather it kind of expands out a little bit, right? And it thinks, in this article, I think the general argument is that, certain service providers are much more successful, right, in retaining key populations in care. So really it depends on where you go, which clinic you end up going to, that will define the likelihood of you continuing to be in care, and therefore likelihood of suppression of viral load. So that's a sense, in a sense that the cascade of care data needs to have a corresponding, I don't know whether you might call it an ethnographic component or a qualitative component that can really flesh out to you, what this story is that the cascade is telling you.
Oke. Terima kasih Ben, terima kasih Mas Ferry atas pertanyaannya. Di sini ada satu peserta lagi yang angkat.
Sorry, saya boleh memberikan pendapatku nggak?
Boleh Mas, silakan. Abis ini kita langsung ke Mbak atau ke Kak Mufitasari ya, yang sudah angkat tangan.
Terima kasih. Saya hanya ini buat Ben juga atau buat teman-teman yang lain. Saya kira kenapa saya bertanya tentang itu sebenarnya untuk membuat bahwa apa yang dilakukan oleh lapangan itu memang akan terlihat gitu ya, dan bisa dikomparasikan termasuk dilihat sebenarnya isunya apa. Saya mengimpikan ya sebuah cascade itu bukan hanya just the numbers. And this is and it's always the same. It's not reach whatever you want. Kenapa? Karena jumlah layanannya terbatas. Jadi jumlah layanan terbatas. Ayo kita kasih lihat benar atau tidak itu gitu. Atau jangan-jangan berhenti dengan seiring dengan waktu gitu ya. Jadi itu misalnya. Dan kemudian misalnya faktor yang lain, saya kira kita bisa membuat satu variabel atau variabel-variabel yang bisa merepresent tentang situasi daerah-daerah misalnya saja. Jadi kita tahu Indonesia itu beragam sekali dan bukan direpresent hanya oleh Jakarta saja atau Jabodetabek, tapi banyak yang variasi lain. Nah, itu yang saya kira kalau kita bisa munculkan mungkin akan memberikan makna yang lebih dalam gitu ya, sehingga satu kali lihat, oh ya kita tahu nih kira-kira isunya masih di sini juga, masih di sini. Terima kasih.
Terima kasih Mas Ferry.
Ya, terima kasih.
Silakan kamu Vitasari.
Ya, terima kasih Mbak Amalia. Saya sebenarnya merespon pertanyaan Mbak Amalia di chat saja gitu, karena kayaknya kalau saya tulis panjang juga ya.
Silakan Mbak.
Jadi sebenarnya mau berbagi cerita saja gitu bagaimana program yang saat ini dikelola oleh PKB DKI, yaitu program pencegahan HIV untuk pekerja seks perempuan yang didukung oleh Global Fund. Yang dilakukan di wilayah Sumatera, Jawa Tengah, Jawa Barat, dan Banten gitu. Kami sendiri sebenarnya PKB DKI sebagai SSR dari program ini juga sebenarnya menggunakan Kaskade ini sebagai salah satu cara yang kami lakukan untuk mengukur sebenarnya awalnya niatnya untuk mengukur capaian program gitu, tapi seperti yang tadi juga sudah disampaikan oleh Ben, Kristal, dan Priyanka, kemudian juga dikuatkan oleh Mas Ferry bahwa ini sebenarnya bukan hanya angka gitu, tapi ada banyak cerita dari angka-angka itu gitu, karena angka-angka itu kan sebenarnya merepresentasikan manusia ya, setiap orang gitu, yang ternyata itu membuat kami jadi menemukan variasi-variasi bagaimana bekerja dalam program gitu, dan ini tidak dibatasi dengan hanya sekedar misalnya kayak definisi operasional atau ketentuan-ketentuan administratif program gitu, tapi kemudian kami menemukan sebenarnya dengan Kaskade ini ada banyak sekali cerita-cerita yang kalau tadi di bagian bawahnya skema atau model yang dipaparkan tadi sebenarnya menemukan itu tadi, awalnya menemukan apa persoalannya gitu, tapi kemudian kami juga kembangkan untuk juga melihat apa yang sudah berhasil gitu, dan memaksimalkan apa yang sudah berhasil itu gitu. Itu juga sebenarnya kami lakukan gitu. Di awal memang sangat banyak sekali tantangan yang dialami gitu untuk membuat jadi satu grafik Kaskade yang kayak gitu tuh sangat menantang gitu sebenarnya, karena kita terbiasa melakukan pengumpulan laporan dan data program itu secara parsial gitu ya, secara terpisah, misalnya kayak hasilnya outreach berapa, kemudian hasil yang dites berapa, hasil ketemu HIV positifnya berapa gitu. Tapi dalam Kaskade sebenarnya kita udah bisa lihat gambaran besarnya gitu, bahwa dari pekerjaan menjangkau sampai kemudian memberikan dukungan ke pekerja seks perempuan dengan HIV positif untuk tetap bisa akses ARV itu jadi kebaca ceritanya gitu, dan itu tadi gitu, cerita-cerita itu yang kemudian bisa memberi makna dari grafik-grafik yang dibuat dalam Kaskade gitu. Kemudian juga sebenarnya yang kami juga kemudian jadi terbaca adalah situasi-situasi yang memungkinkan atau mendukung teman-teman pekerja seks perempuan untuk tetap bisa akses ARV, itu kemudian juga jadi muncul gitu, dan hal-hal yang memungkinkan untuk bisa diadvokasi ke depan gitu, terkait dengan upaya untuk memastikan teman-teman pekerja seks perempuan tetap bisa akses ARV dan memaksimalkan kesehatannya. Artinya ini kelihatannya mungkin cuman dari HIV-nya saja gitu, tapi ternyata di balik itu kami juga ketemu misalnya berapa jumlah pekerja seks perempuan yang terpapar IMS gitu, yang positif IMS gitu. Mungkin itu dilihatnya nggak terlalu berhubungan dengan HIV, tapi sebenarnya itu punya kaitan yang cukup erat gitu dengan potensi adanya teman-teman pekerja seks perempuan yang mungkin akan terpapar HIV gitu. Terus kemudian memastikan bagaimana ketersediaan logistik seperti kondom dan pelicin itu juga bisa tetap diakses oleh teman-teman pekerja seks perempuan gitu. Akhirnya itu dari Kaskade yang mungkin hanya satu slide itu tuh ceritanya jadi banyak gitu. Itu yang kami kami temukan sebenarnya Mbak Amalia dan teman-teman. Yang kadang juga itu bikin kami overwhelmed juga gitu dengan informasi-informasi ini gitu. Dan akhirnya kami jadi punya data yang fix gitu, yang valid gitu terkait dengan misalnya berapa pekerja seks perempuan yang sampai sekarang masih akses ARV itu orangnya kemana aja, orangnya siapa aja, itu jadi kita bisa benar-benar bisa tracking gitu orangnya gitu. Bahkan misalnya kayak kapan dia akses ARV itu kami masih catat tuh tanggalnya gitu, walaupun itu memang udah udah beyond kebutuhan programnya gitu. Kalau mau minta kebutuhan administratif programnya sebenarnya ya udah sampai 3 bulan aja udah selesai gitu. Tapi itu tidak menjawab 90 yang ketiga kan sebenarnya gitu, berapa pekerja seks perempuan dengan HIV positif yang tersupresi gitu, viral load-nya tersupresi, itu yang nggak menjawab gitu. Itu kemudian jadi, itu juga kami lihatnya dari Kaskade gitu, kita jadi akhirnya nyadar Kaskade kita nggak lengkap gitu, nggak komplit gitu, sehingga kita kejar untuk melengkapi datanya gitu, sampai kemudian walaupun mungkin datanya nggak sampai ribuan gitu, tapi kita bisa pastikan benar gitu masing-masing orang dari misalnya 100 orang ini tuh kemana aja, sampai sekarang masih akses HIV atau tidak, kemudian dia ditemani sama siapa, kondisinya dia saat ini bagaimana, itu kita jadi punya datanya gitu, yang kemudian ini bisa jadi pembanding dari SIHA yang dimiliki oleh pemerintah gitu. Tapi ini hanya baru dilakukan di Sumatera, Jawa Tengah, Jawa Barat, dan Banten gitu. Memang belum, mungkin perlu proses yang agak banyak gitu ya, effortnya agak besar gitu kalau misalnya ini mau dibuat dibuat jadi satu Indonesia misalnya gitu. Dan ini masih kami cobakan di satu populasi kunci gitu, belum. Sebenarnya mungkin teman-teman dari Yayasan Kerti Praja atau mungkin teman-teman LSM lain juga melakukan hal yang sama gitu. Mungkin kita belum ketemu aja prosesnya gitu. Untuk kita bisa saling bertukar informasi seperti ini. Mungkin itu dulu Mbak Amelia yang saya bisa cerita gitu pengalaman kami menggunakan Kaskade, kemudian ya kebingungan kami di awal-awal gitu kan menggunakan Kaskade gitu. Dan ya sampai sekarang ya kami masih menggunakan itu dengan menambahkan informasi-informasi yang sifatnya kualitatif untuk memperkaya. Sebenarnya bukan hanya memperkaya tapi mendukung dan menceritakan Kaskade itu gitu, dan itu bisa jadi bahan kita melakukan advokasi ke depan gitu Mbak Amelia.
Makasih banyak Mbak Mufitasari. Menurut aku yang baru disampaikan penting banget bahwa tidak bisa dilihat hanya sekadar angka, tapi justru Kak Mufitasari menekankan tentang cerita pengalaman dari teman-teman pekerja seks perempuan yang justru mereka memproduksi pengetahuannya sendiri ya, dan nantinya akan bareng-bareng digunakan untuk menjadi bahan advokasi. Makasih banyak ya Kak Mufitasari untuk sharingnya.
Sama-sama Mbak Amelia.
Untuk Ben, Kristal, dan Priyanka, nanti bisa sekalian kalau misalnya ada yang mau direspons dari ceritanya Kak Mufitasari. Saya juga mau baca apa yang ada di kolom chat dari Rita, KPA Kota Jakarta Timur. Thank you for explaining about the Kaskade. My question is, when should we make the Kaskade? Is it per month or per semester? Or would it be depend on the need on making decisions? Also on the output and outcomes that will be followed up. Ada satu saran dan masukan dari Ceris, lebih tepat sasaran lagi untuk edukasi dan advokasi terkait penularan HIV/AIDS untuk komunitas populasi kunci di pelosok daerah yang masih belum paham terkait isu HIV. karena masih banyak angka penularan HIV di kelas level paling bawah untuk edukasinya, termasuk IMS. Jadi jangan hanya mengambil data atau VCT apabila ada yang reaktif. Jadi masih banyak orang yang VCT dan reaktif tapi masih takut untuk terapi ARV. Oke. Sekarang saya mau minta komentar dari Ben, Kristal, atau Priyanka.
Priyanka, would you like to say anything about the kind of other question? Sorry, that first question about what intervals, would it be useful to produce the Kaskade report according to the Kaskade?
Sure. I should mention that a lot of my experience comes from other infectious diseases and not particularly focused on HIV and the surveillance that happens here in Australia, both syndromic and sentinel surveillances. I can give an example of flu. Influenza is done on an annual basis, mainly because there's a part of the research that informs vaccine development, a part of the research that informs when the vaccine rollout will start annually. So that kind of 12-month cycle is followed for influenza. And it seems reasonable for a lot of sexually transmitted infection surveillance here in Australia as well. Annual reports about gonorrhea, annual reports on other diseases are produced depending on the testing numbers. I would say the entire cascade, including all the steps that we discussed from the public health questions that the approaches for HIV monitoring and evaluation, if it runs on a 12-month cycle, gives enough time to define the question, situation analyses, then the determinants research as well. What are the social determinants and health determinants that are causing and are more associated with HIV, and then the monitoring and evaluation part and the success of a program. That would be based on the experience that I have in other infectious disease surveillance and monitoring and evaluation. A 12-month cycle is reasonable, but it also then depends on funding. It also depends on when the situation reports need to be produced, who wants to get the information for policy purposes, for advocacy purposes, for outreach purposes. So it depends on a lot of those factors. But running it on an annual cycle gives opportunity to plug all of these activities in between while the testing numbers are coming in, while the burden of the disease is captured, and the evaluation of the program happens. Ben, did you have anything to add to that, Crystal or Ben?
That's a great response, Priyanka. Crystal, did you have anything to add?
No, not in response to the question. That was excellent. Thank you, Priyanka.
Yeah, I think that is really interesting, though. You've given it a nice indication of perhaps sometimes a gap between the use of data for the purposes of public health and the use of data for the purposes of, say, other reasons, such as the obligations of reporting to funders, and those two things can be thought of as distinct. So I guess the question then becomes, who is asking for the report, or the report on according to such a time scale? Why might they be doing that? And then whether or not it's possible, I think, Priyanka, you raise a good point, right? The feasibility, I guess, of undertaking this complex and major kind of piece of work on a very frequent basis might be just simply too difficult. So that's really interesting. Thank you.
Ben, mungkin juga menarik untuk lihat lagi di dalam presentasi yang Ben tadi lakukan ada pipa yang bocor. Menurut saya itu menarik penjelasannya untuk menjelaskan peran teman-teman dari CSO juga.
Sorry, Amalia, what was the last?
I think it's really interesting if when you presented about the pipes leak, I think it's important to show the contribution of CSO.
That's right. Yeah, absolutely. So the contribution of community organizations is so vital, you know, and I mean, I guess the leaky pipe illustrates the collection. I guess what that illustration is trying to show is that data is collected in order to demonstrate points along the line where, or draw attention to points along the pipe where you're losing people, right? So people are kind of lost from the system in the form of leaks, so that you would try and, you know, go with a bucket or you know, or with perhaps a repair kit, I don't know, and try and repair the pipe at different points along the line. But of course, the people who are tasked with both identifying where those leaks are coming from, you know, using that metaphor, where those leaks are coming from, and then further kind of, you know, going to the leak and trying to work out how to plug it, or perhaps how to kind of catch that dripping water, to use that metaphor again, CSOs themselves, right, and CSO staff. So I think you can, you know, to me that really illustrates the kind of, you know, amount of work that CSOs are doing, you know, both in terms of data collection, that's very interesting to hear the story earlier from
Mufita Sari.
Mufita Sari. Yeah, thank you so much for sharing that story. I think that was you know, really interesting. Yeah, it helps to kind of illustrate this process in a different way. Crystal, did you have anything to?
Yeah, I just to echo what you were saying as well, Ben, and I think that as you mentioned, Amalia, the leaking pipe figure is very interesting, but the way these data are visualized in the first instance is very interesting. Something we talk about a bit in my line of work is the idea of black boxing, often in relation to things like AI and machine learning, but also data visualizations can black box the data behind that visualization as well. So to put it another way, by visualizing data in these very digestible but also very simplistic ways, we hide the processes that led to that data telling the story that it is telling. And I think that that is really important to remember, because as everybody here would be aware, there's a lot of, for any data visualization, not only the Kaskade, there's a lot of smoothing and cleaning that happens to data in order for it to be able to be visualized in these very digestible but very simplified ways as well. And that cleaning can, you know, by its very nature, it has to render invisible some stories or some sticking points, so that the data is able to be used in this very specific way. And that can be problematic, like black boxing the nuances of that data through visualization can be problematic sometimes, because it can hide the barriers to care or whatever it is that data is focused on. So I think that's a really interesting observation about data, about the visualization, Amalia, about the leaky pipe.
Thank you so much, Crystal. Oke. Di dalam kolom chat ada pertanyaan lagi dari Mas Ferry, yaitu menanyakan bagaimana kondisi Kaskade di Australia. Tapi sebelum menjawab itu, atau mungkin itu juga bisa dijawab pada kesempatan lain, saya juga mau menegaskan bahwa sebenarnya diskusi ini adalah awal mula sekali untuk kita membuka diskusi dengan teman-teman yang hadir di sini untuk mempertanyakan Kaskade itu sendiri, supaya kita tahu bagaimana cara kita mengumpulkan datanya, bagaimana cara kita menggunakannya. Tadi dari cerita Mas Ferry atau cerita Kak Mufita, kita bisa tahu bahwa ada banyak data yang tidak ditampilkan di sana, tapi dimiliki oleh teman-teman yang sebenarnya justru memproduksi pengetahuan yang dimiliki oleh teman-teman yang ada di lapangan. Dan menurut kami tentu saja itu jauh lebih penting. Sayangnya waktu kita terbatas sekali, tapi kami sangat ingin mendengar cerita dari teman-teman. Kami meninggalkan satu link dari Menti, akan saya taruh di dalam kolom chat. Teman-teman boleh klik di situ, kemudian nanti boleh jawab Kira-kira data apa aja yang biasanya diambil, digunakan untuk apa. Nanti kita akan diskusi ini lebih lanjut bersama teman-teman lagi supaya untuk terus memperkuat bagaimana perawatan dan pencegahan HIV di Indonesia. Saya mau mengucapkan banyak terima kasih buat teman-teman yang sudah hadir di sini. Makasih juga buat Ben, Kristal, dan Priyanka yang udah kasih waktu untuk menjelaskan. Kami berharap kita bisa ketemu lagi nanti untuk bahas ini lebih lanjut. Kalau teman-teman masih ada pertanyaan, silahkan tetap boleh tulis di dalam kolom chat. Nanti bisa kita follow up juga setelah ini. Sekarang acaranya saya kembalikan kepada Mervin. Silakan Mervin.
Oke, baik. Terima kasih Mbak Amal, Ben, Kristal, dan juga Priyanka. Terima kasih banyak telah mengisi kegiatan hari ini dan semoga juga tadi terkait data HIV dan juga diskusinya bisa memang benar-benar membuka sebuah opportunity gitu untuk kita bisa belajar bersama terkait penggunaan data, pengelolaan data, dan implikasinya tentunya kepada pengembangan program HIV ke depannya baik di Indonesia maupun di region-region lain seperti itu. Baik, kita sudah di penghujung acara. Kita akan mengadakan sesi foto bersama dulu untuk dokumentasi. Akan dipandu oleh tim media dari PPH Atmajaya. Rekan-rekan Bapak Ibu bila bersedia diperbolehkan untuk mengaktifkan kamera agar dapat terlihat, dan nanti rekan saya Armadina akan memandu untuk menghitung diambil fotonya.
Ini terhadap.
Iya, selamat sore Bapak-bapak, Ibu-ibu sekalian. Jika bersedia dan berkenan untuk nanti di-post fotonya di sosial media PPH, boleh diaktifkan kameranya, tapi memang kalau memang keberatan itu nggak apa-apa. Oke, saya tunggu ya. Oke, saya hitung sampai 3, 1, 1, 2, 3. Sorry, ada yang sebentar, ada yang masuk chat. Oke, ulang lagi 1, 2, 3. Oke. Sebentar, satu lagi. Oke, 1, 2, 3. Oke, sudah selesai. Terima kasih. Thank you so much.
Makasih.
Terima kasih.
Terima kasih
Terima
teman-teman.
kasih semua. Sebelum menutup acara, nanti rekan-rekan akan dikirimkan sebuah form evaluasi oleh panitia ke dalam email, nanti mohon diisi. Kemudian juga nanti bila ada sertifikat e-sertifikat juga akan dikirimkan lewat email. Dan sepertinya dari kami sudah seperti itu. Mohon maaf bila ada kesalahan pada kegiatan hari ini. Terima kasih banyak semua dan sampai jumpa di kegiatan-kegiatan PUPT PPH selanjutnya. Terima kasih semua. Terima kasih.
Makasih Mervin. Makasih Ben. Makasih Amal.
Terima kasih semua.
Terima kasih.
Kristal.
Thank you semuanya. Dadah.
Bye-bye. Dadah.
Keren. Bagus Mal.
Terima kasih.
Terima kasih.
Bye everyone. Thank you so much.
Bye.
Thank you.
Good night Moon.
Thank you. See you next time.